Hi, everyone. I'm Kathy Kamisa. I'm the program manager for the Assisted Outpatient Treatment Services program at CarePlus. And it's abbreviated AOTS or AOTS, depending. Within the state, the law is known as Involuntary Outpatient Commitment. It originally kind of stemmed from Kendra's law in New York, which came about in the late 90s, early 2000s. And it's basically a program that was designed to treat people who don't recognize that they are sick. And when they don't take medication, they do become violent, either to themselves, to others, or to property. So for us, it's a court-ordered program, but it's for outpatient treatment instead of inpatient treatment. So it's really designed for somebody who has a history of some kind of dangerous behavior when they're not on medication, but when they are on medication, they respond well to the medication insofar as it controls the behaviors and largely some of the symptoms. And I do apologize because if you hear a vacuum cleaner, they're kind of cleaning our office right now, but that should stop in like a minute or two. So for those people, for whatever reason, they have a hard time complying with treatment in the community on their own. So it's either because, as someone said earlier, they're not able to identify that they need medication, they're not able to recognize their own symptoms, they're in denial about their illness. And sometimes the symptoms just present in such a way that they don't believe that it's an illness. So it could be somebody who experiences paranoia and not necessarily hears voices. They think that that's what's really happening, that that's what's in their head, and you can't convince them otherwise. And they don't believe that the medication will help them or has helped them in the past. So with the court order, we mandate outpatient services. So that includes medication, that includes different psychiatric programs. The one thing that we can't do, even though it is mandated, the medication, we cannot forcibly administer the medication. So yes, they're court ordered to take the medication, but if they're not compliant with that medication, we have to initiate the screening service, or I can initiate a transport order myself to have them evaluated by screening if the person not taking medication means that in the past they've had some kind of dangerous behavior, and that's what we're trying to prevent. We usually use that more as an intervention though. So when we screen people, it's not generally at the point when they're in a full-blown psychosis. It's really used more as an intervention and a deterrent for the hospitalization. And a lot of times we can prevent the hospitalization in that way by having them evaluated, then they agree to restart the medication, and then we can kind of move forward. In Bergen County, we've had this program with CarePlus since 2014, and it was really October 2014, so it kind of really implemented in 2015. Within that time frame, I've been with the program since it started. I've been managing the program for the last 3 years here. So we've seen a number of clients come through our program. We have a lot of success stories with people that we have worked with. Our team has a psychiatrist previously to about a month ago. She wasn't a treating psychiatrist, so she wasn't prescribing for our clients. She was meant more to be an independent assessor of someone's continued need for the program. So for us, because it is court ordered, our clients' commitment status with the program is reviewed at least every 3 months within the first year. If they continue with us past the first year, it's every 6 months. So what that process looks like is a court hearing, there's a judge, there is an attorney that represents the client or the patient, and then there is an attorney that represents the county. Our psychiatrist testifies, I testify, and the consumer testifies as well. And it's meant to evaluate their status in the program to see if they continue to meet the commitment criteria for the program. For us, it's a little bit different than inpatient commitment in that in an inpatient commitment, the person is in imminent danger. So right in that moment, in the next 24 hours, it's likely that something is going to happen or something has already happened. With us, it's a foreseeable future danger. And that's sometimes a little bit hard for people to differentiate between the inpatient imminent danger. So the way we evaluate that is based on somebody's history. So if they have a history of going on and off medication, and when they're off medication or not engaged in any kind of mental health services, there has been some kind of danger that either puts somebody else or themselves or property at risk, then we can safely say that because of their history, in the foreseeable future, it's likely that without the services that we're implementing, they would then become a danger. So that's what our doctor evaluates and testifies to. As of last month, she is now able to treat some of our patients. Her role's expanded, and we've kind of changed the way our program works amidst COVID. Previously, prior to COVID, we were very involved with our patients' treatment, but not necessarily the primary treatment provider of those services. So they might be in a program like CSC or in a program like a partial care program. Right now, we don't really have those options. We don't have partial care for people that's in person. And we found with this population, they are not good with telehealth. So unlike a lot of the other programs, we have remained largely face-to-face with our clients, and we've taken over a lot of the roles that other programs did. We didn't previously have group therapy. Now we have a women's group that started last month. We didn't previously provide individual therapy. We would usually refer out to other programs, either within our agency or in other agencies, and coordinate with those treatment teams. But because our population did not respond as well to telehealth services, we started doing those services ourselves so that they would be able to remain out of the hospital and we could still follow up with them. Our team is made up of myself and 3 master's level case managers. We also have the psychiatrist, as I mentioned. We have a total caseload for the program of 40 consumers. And most of the time we are at our capacity, but typically we enroll 1 to 3 new people each month. So we do have kind of a rolling waiting list that I maintain, just because we're often full. And we did recently last year expand. We used to just have the 3 of us, and we expanded to include a 4th person. And we've since requested an additional expansion to make our services more available. With our program, the person does have to be 18 years old or older. They do need to have a primary mental health diagnosis. That doesn't mean that there can't also be substance use history or that as a contributing factor, but if somebody has a full-blown addiction, that's probably a little bit too much for us to manage in IOC. And the reason that is because the commitment law itself does not expand to include substance use. So the most I could mandate by way of substance use treatment in an outpatient program would be a dual diagnosis partial care program. I can't mandate inpatient treatment or anything like that. I can't mandate Suboxone or naltrexone or any of the medications that would help with somebody's addiction. So that's kind of, there is a pending kind of expansion in its own right for substance use treatment, but it's still in the New Jersey legislature, so it hasn't expanded there yet. With us, we tend to run from 12 to 18 months for enrollment. That's not by any means a hard rule. We've had people complete within 6 months. It's very rare that we discharge somebody before 12 months, and it's more frequent that someone discharges around the 18-month mark. But I do have people that we've had in this program since it started, and that I will probably have in this program for a long period of time. And those are people who are usually a little bit older, who have kind of cycled in and out of the mental health system for a long time. And while they're compliant with the court order, even though we've worked with them and we've had different service providers involved, for whatever reason, they still don't understand that they would need to take the medication or need to remain with the service providers after we discharge them. So they still remain a risk. So we continue to maintain them with the court order. For our population, we've seen recently that it is a lot younger that we are getting within the last year. Previously, it used to be 40 and over. That was the main referrals. Within the last year and a half, we've had people that are 20, people that are 21. Are right now, half of our caseload is under 27. So we have a pretty young population right now. We do try to work with people and their families. With us, it's a little bit different. Once we do enroll somebody, almost every time, if they're living with family or if their family is involved, we'll make it a contingency of the court order that we do need to have open communication with whoever it is, the parents, a sister, somebody, at least one person in the family that lives in the household or that's very involved with the person. And that actually is a large majority of our population that has family involvement. It's very rare that I have somebody in this program that doesn't have any family involvement. With medications, we tend to lean more on the injectable medications because it's easier for us to monitor. Because we don't have nursing staff within this program, we can't function like a PACT program would, where we could daily monitor medications. Telehealth has actually helped us a little bit in that respect, in that if somebody is on oral medication, but we know that because like partial cares are closed, and we used to have people in our own partial care and they would be monitored Monday through Friday with the oral medication. Now they aren't, and those medications might not come in an injectable form. We were able to do that with telehealth, where we could visually see that the person was taking the medication. So that became very helpful for us when COVID really kicked off and kind of eliminated a lot of the services that people were getting before. For us, we also tend to work a lot with people who don't have a lot of a work history, or at least a lot of a significant work history. So we do try to engage people in either supportive employment services or some kind of educational program, because we found that our most successful cases were ones that we discharged when they were engaged in other community services outside of just mental health programs. So either they were working or they had enrolled in school, they had some kind of volunteer job, they had something that engaged them within their own community that made it a little bit easier for them to continue taking the medication, but also gave them a purpose and a reason to follow up with services and to want to be out of the hospital and want to stay home. The way that we tend to present family involvement, just to go back to that for a minute, with our population, is when we engage someone in an intake, if they're resistant to having their family involved, it's typically the family that's engaging the screening service previously. So we tend to frame it in a way where we can help them speaking with their family, and sometimes being a prevention from engaging the screening service if we can have them see the psychiatrist sooner, have them engage with a therapist sooner. We also do family therapy with some of our consumers. So depending on the circumstances and the situation and what other providers we have them linked with, we may also be able to do family therapy with them. We're grant funded, so it doesn't matter if someone has insurance or not. Similar to CSC and the other programs, the only hang up on that is for medications. But we do have some funding to cover medications, but long-acting injectables tend to be pretty pricey. So it would be difficult for us to do that on a long-term basis. So we do try to get people linked with either Medicaid or some kind of insurance benefit when we first enroll them. The other requirement for us is that the person does need to have housing when we enroll them. So it doesn't have to be with family, it can be independent, but we can't take somebody who is going to be discharged from a hospital without an address, because we need to have somewhere to find them, somewhere to provide the services, somewhere to meet with them. If they don't show up for an appointment, we need to have some place to look for them. So that we've had in the past some people that have lived in a shelter, in the shelter in Hackensack, but that's a pretty rare occasion. Usually people have their own housing when they're discharged. The majority of our referrals do come from an inpatient hospitalization. So typically somebody might be outreached by screening or for whatever reason end up in the hospital against their will. And as part of the discharge plan, they're referred to our program. We can take community referrals from other providers, but that's more of a rare occasion. And because the person would already have to be following up with a psychiatrist who feels that they need the outpatient commitment. For us, even though the term is involuntary outpatient commitment, initially they do have to agree to the treatment plan. So we find a lot of times that's easier to have happen when they're in the hospital as part of a discharge plan than it is as in outpatient. We can also take people who screening is evaluating, who, if they feel that they're on the fence about whether or not it could meet an admission or a discharge back into the community. We've only done a couple of them, and a lot of that is because over the last couple of years, we've had a pretty full census. So we just haven't had the availability to provide that intervention.